everybody, my name is Marie Kilduff and I'm the Interim Director of the National Clinical Leadership Centre for Nursing and Midwifery, the Office of the Nursing and Midwifery Services Director in the HSC. You're very welcome to our third webinar today. The webinar is entitled Nursing and Midwifery Clinical Leadership during COVID-19, Sharing the Learning from Midwifery Services. I'm delighted to introduce our expert panel today. Our expert panel consists of Ms. Fiona Hanrahan, who is the Director of Midwifery and Nursing, Rotunda Hospital in Dublin, Ms. Clare Fitzpatrick, who is a Clinical Midwife Specialist in Lactation in Midlands Regional Hospital, Portlaoise, Ms. Yvonne Moloney, who is a Registered Advanced Midwife Practitioner in Diabetes in University Maternity Hospital, Limerick, and Ms. Carmel Connolly, who's a Clinical Midwife Manager in Parent Education Services, Salta University Healthcare Group. I'd also like to introduce Dr. Clare Lewis, who's the Deputy Chief Nursing Officer in the Department of Health, and Clare is going to be taking notes throughout the webinar and will summarise the key points raised at the end of our webinar. So without further ado, I'm going to start with Fiona. Fiona, lovely to see you again today, and thank you for joining us on our panel. Fiona, we've been speaking over the last few days, and in preparing for today, we've been talking about COVID and how it has actually impacted across all services. And sometimes there is a perception in terms of maternity services, and we were saying this, that, you know, how could it affect maternity services? Because people aren't going to go in there if they're sick. It's the acute services that manage the COVID situations, but obviously it's seriously impacted every service. And the first question I'm going to ask you to speak to that is, how do maternity services differ to general hospitals?
Thank you for that, and that's a really good question, because it is really important to recognise that maternity services are very different to general hospitals. I saw it written somewhere that during COVID every journey stopped except the journey to birth. So women who got pregnant last year didn't think for 1 second they would be giving birth during a global pandemic. I suppose maternity services have large volumes of patients, most of whom are well, but some of whom require specialist care. You can't deliver antenatal care remotely. You have to put your hands on a patient to see everything is okay. So you can't do remote monitoring of patients. So we had our expected volume of women who were going to give birth right during the pandemic. And I suppose we were trying to manage our patient groups who were living in the community, you know, children going to school, all the usual stuff, and trying to manage them and manage our staff and manage our buildings here. So our services carried on as normal. We had to provide the same level of antenatal care to the women that were coming to us during the pandemic.
And, you know, having said that, Fiona, I'm sure there were challenges. So what were the unique challenges faced by the Rotunda Hospital? And in speaking to that, could you just tell us how you overcame them as director with your team?
Yeah, I suppose, you know, for every woman, I mean, this sounds like the most obvious thing to say, but every woman who's pregnant has a due date. So you know she's going to come into you to have her baby. So you can't postpone that, you can't delay it, it's going to happen. So recognising that, recognising our population were at risk of contracting COVID due to where we're based, we sort of established a hospital within the hospital here, and we established red COVID zones where we would admit women who were positive for COVID tests, where we could cohort them or isolate them as required. So we had literally a separate labour ward, a separate antenatal ward, a separate postnatal ward for women who had to be admitted here. We sort of decanted a lot of our services through daycare. So we tried to sort of do monitoring for conditions like preeclampsia more through daycare. We introduced very quickly actually remote monitoring for gestational diabetes. So women with gestational diabetes have to check their blood sugars regularly. So we did a lot more of that remotely. One of the things that we did here actually was we set up remote parentcraft classes. So all of our classes are now on YouTube, and then we do Zoom Q&As for women as well. So you're trying to keep your services running as normal, because I think in this very frightening world, to be having a baby, women have to feel safe and protected, because you don't want to bring a newborn into the world feeling scared about the future. So we try to keep our services running as normal as possible, while in parallel looking after women who were COVID positive in an appropriate way and caring for our staff at the same time. So yeah, I have to say, it was actually, I was very proud of the team here, because everyone stepped up and said, what can I do? You know, what can I do to help? We were lucky here that we have laboratory testing on site where we can rapid test for COVID if required. So we very quickly set up a kind of a drive-through service to swab staff and patients as required. And where patients come in with symptoms, we can get a swab back within 45 minutes. So at least we had the ability to diagnose COVID very quickly. One of the difficult things was locking down and visiting here. Having a baby is very much a family event, but we had to take the very tough decisions around visiting to sort of stop all visiting in the hospital initially. And actually, what was very difficult for us was really deciding to stop visiting in the NICU except for the mother. So for a period of time, the mother's partner wasn't allowed in the NICU, and that was very tough. And you have to sort of take these decisions with the best interests of everyone at heart, and then you take the flak that goes with it. Now we've reintroduced the partners into the NICU, but initially nobody really knew what the hit would be in terms of who would get COVID. And we were getting sort of international stuff around it doesn't affect pregnancy, but you never really knew. And we were worried about our newborns and our NICU, where the most fragile babies in the country are. So we had to really kind of separate our NICU and mind it separately to make sure that no COVID got in there.
I suppose, as you're presenting all of that, I'm just conscious of the staff, Fiona, and I'm wondering how it's staffed during this period, because I'm sure all of those changes bring a lot of challenge and stress to people. So could you talk us through how the staff are and how you've managed to mind them during this time?
Yeah, I think you're absolutely right. I think for all of us, I mean, I know I was frightened, and I'm sure you were frightened, but you can't show fear, can you? So I think we're lucky here that we're a single campus. We have about 1,000 staff altogether. That includes all disciplines. And we know each other very well. So that gave me some comfort that you could reach out to all your staff fairly quickly. I think one of the challenges for clinical staff was they were seeing their colleagues in HR and finance being able to work at home. So a lot of staff that could work at home worked from home, and that was great for them. But you rely on clinical staff to get up in the morning, to come into work, not knowing what they're facing. So what we decided here was to be the one source of truth for our staff, because there was so many guidelines coming in, so many directives coming in, that we were trying to interpret them and get messages out to our staff. So one thing I think we did really well here was communication with our staff. We sort of thought about the fact that most clinical staff don't have access to an email, a hospital email address. Most clinical staff don't go onto a computer every day to check their emails. So we set up a kind of a hospital-wide WhatsApp group, and we use that as a source of communication. And that was for not just clinical staff, that would be our catering, portering, household, the whole team approach. So then what we did was a series of sort of YouTube videos that went up onto the WhatsApp, where myself or Fergal, who's the clinical director, would go take staff through what we were thinking and what was happening. So as the changes happened really rapidly, but every day we would do a video to say, this is what happened today. This is how many staff are affected today. This is how many patients we have today. So I was worried about rumours. I thought, having rumours running around a hospital, I'm sure you know from working in hospitals, it's a rumour mill. So we needed to be the source of truth. The executive management team needed to be the people who knew what was going on and were able to cascade information. We couldn't hold big town hall meetings. We couldn't hold big group gatherings. So we had to harness kind of social media and technology and use that as our way of getting to our staff. And I think staff here felt very safe coming in. Our students, I kind of felt, our students came here, their fourth year students worked right through the pandemic, and they were so brave because they're young, inexperienced, leaving their families. I'm sure the families were scared about them coming to work. And in fairness, they stepped up and they came in, and I'm so proud of them because they've now just qualified. And I think what they've learned during this pandemic will stay with them for their whole careers, So yeah, I think there was a lot of learning about managing staff and managing expectations. And actually a big change for us was enabling staff to work at home. So we had medically vulnerable staff that had to work from home. So having to get IT out to them, get them sorted to work from home where they could. And then a number of our ancillary services who could work from home were able to work from home, and that was never heard of in the health service before. So it's been a massive change for everybody. I think we've done very well with staff here, thankfully.
And I suppose that leads me on to my next question, Fiona. And from what you've just presented there, I definitely think you've done so much for the staff, and I think your presence, as you said, was key in the communication to support them. And my next question is, and you already answered part of it, but what did you do well, and what do you think you could have managed better over the last few months?
When I reflect back on what happened over the last number of months, what has struck me is that we really hadn't considered the impact on particularly our overseas staff here. We have staff from all over Europe working here, France, Spain, Italy, Germany, and of course the Philippines and India. And for them, not being able to go on holidays was not going home. So a lot of these staff haven't seen their families in months. And a lot of the European staff will be frequent flyers at Ryanair to go home and see family for a weekend, and they haven't been able to do that. It's had a massive impact on them, and even probably more so for staff from the Philippines and India, where they have elderly parents, perhaps their children living with their parents at home, and they have no opportunity to go home. There's not a chance they'll get there. They normally, a lot of the staff from the Philippines or India would normally sort of save money and travel home every couple of years. So this could be the year to travel home, and they may not have the opportunity for a couple of years. So I think the impact on their mental health has been huge. I think not just us, but as a health service, we're going to have to acknowledge the stress this is placing on them. They live here, they work so hard amongst us, and yet they're not going to see their families for a long, long time. And they carry the fear that, there's a lot of COVID in India at the moment, and the rates in the Philippines are quite high. So they worry about their families as well, while trying to deliver services to our patients and to us here.
And as you described that, I suppose it's something, and we were talking about this the other day, Fiona, I suppose in Ireland, we're struggling ourselves with the isolation of the different levels, but I'm just thinking how awful it must be and how hard it is for people who are away from their families completely in a different country. So that is something that I think we could all learn and consider going forward in any service to support our overseas colleagues. I suppose moving on, Fiona, you're the Director of Midwifery and Nursing in Rotunda Hospital. So I think you're in a prime position to actually talk to the midwives that are listening here today. Have you any message you'd like to give to them as they're listening to the webinar?
Yeah, I suppose there's two things: is keep calm and carry on, because we've done phenomenally well for the first wave of this pandemic. We now know what we're doing. I think when I look back to March, where it was a lot of sort of almost educated guesswork, but now we know exactly what to do. We know about PPE, so we know exactly what we're doing. We know how to care for patients who have COVID. We know how to mind ourselves. We know to wear our masks and wash our hands. So I think just keep going. It is a long haul, and it's a marathon, not a sprint. And I think just mind each other, because you can't look after patients if you're not looking after yourself and your colleagues. That would be my main message, I think.
Fiona, thank you very much. I think that's a really important message, and thank you for giving us your overview of your experience. We're going to move on now to Clare Fitzpatrick. As I said, Clare is a clinical midwife specialist in lactation. And Clare, from your submission, you developed and presented a very interesting initiative. And just could you tell us about the initiative you led in response to COVID-19?
Yes, Marie, and thank you very much for inviting me to take part in this webinar today. So the initiative that I led out on because of COVID-19 was the way in which we deliver antenatal education in breastfeeding to women within our service. So we know that the education that a woman receives on breastfeeding in the antenatal period very much influences her breastfeeding journey, the amount of time and the success that she breastfeeds for. When COVID happened, we had to pause. We had to stop the antenatal education that we were doing, which was face-to-face. Traditionally, the women would come into the hospital for face-to-face education classes here, that they were held fortnightly within the hospital. We needed to pause for the safety of the women within our service. So we had to reflect on what we were doing and think about how we would go ahead with a safe service but continuing to provide education. So we did that. We put together a plan to provide education remotely. It needed to be accessible, convenient for the women, but to meet their needs. So we now deliver education through email, phone support, by WebEx, and it's been a very successful venture.
And Clare, it's fitting that we're talking about this, given that it was National Breastfeeding Week there 2 weeks ago. So, and
yes,
it's great to hear that you were able to carry on the important aspect of care during the pandemic. I'm just really conscious that a project like this needs the cooperation of so many people. So I'm wondering, in terms of influencing your stakeholders to become involved in the project, could you tell us how you did that?
Obviously, the women were the centre of our care, and we needed a service that suited their needs, that was safe for them, that they were able to access, and that provided the information and the education that was right for them at that time, that particular time. So we needed the women, we needed to be accessible for the women. So they were at the very centre, they were the main stakeholders involved, and whatever plan we had in place, it needed to be convenient for them to access that education in a safe environment, so remotely. The other stakeholders involved were the management in the hospital, the senior management. We needed them on board, and absolutely they were very much on board. They were very positive. We needed, the technology. So we needed to get a laptop that was Wi-Fi enabled. We needed a smartphone. I had to have a new email address generated, and that happened very quickly, all of these things, so that the women could contact me directly on a generic lactation email address. And I have to say the positivity from the management and their support was fantastic. And then also our own colleagues, so the midwifery staff in the clinic, in the ward environment, the clerical staff that were involved, anyone who had direct contact with the women, because this was a whole change of process. You know, we have been delivering antenatal breastfeeding education for a long time in the same way, and this was a big change. So we needed everybody on board, and I have to say I was very proud of all my colleagues. They were all fantastic. Whatever needed to be done, they were willing to do in order to provide the service that the women needed at that time. It was fantastic to see.
And it sounds like a really good collaborative process as well, Claire, with the different people that you've spoken about and the different professions involved. Can I just ask, I'm sure it wasn't without its challenges. So could you tell us just about some of the challenges and then the benefits of the initiative?
Yeah, absolutely. So I guess some of the challenges were, like for me, was upskilling. You know, the technology. I was very used to my smartphone. I was very used to social media, but I have to be truthful. I had never really used Zoom. I didn't really know what it was, or WebEx, or Attend Anywhere. So I needed to upskill myself on all of these platforms to find the right one. And there was the practicalities involved as well. Like, we don't record a woman's email address when they book in for their antenatal education. So how do we get this information out to women? How do I actually invite them to a WebEx class if I don't have their email address? So we were able to get round those challenges, you know, by generating that lactation email address. We were able to put that on the women's combined antenatal card, so they now had my email address. The midwives, they will book them in for a class, but they will get the women to email me directly. When the women emailed me, I was able to then email them out an information email with lots of information sites, videos, all research-based, really good sources of information that I could send back to them straight away, that they could read, they could link into to inform themselves. And then I was able to invite them to a weekly WebEx breastfeeding education session as well. And the fact that I had a smartphone, it was accessible. So even if I was on the ward doing my rounds, you know, it wasn't a day later that I was getting back to women. I could access my emails from wherever I was at that time, so I could get back to them quite quickly. So everything kind of worked out well. It was challenging, you know, if anybody was concerned that there was a change in their role that they weren't sure of, everybody talked about how they were feeling. It was an anxious time at the beginning of COVID, because there was so many changes taking place within our hospital so quickly. But I think everybody talked about how they were feeling. We communicated quite well. We explained the process, so everyone was really, really happy to make these changes and to get on board with everything. So I guess you know, it's looking back now, I do have enormous pride in everybody and how well we all worked together, which was fantastic, because it did continue to help to provide that service for women in our care.
And it definitely sounds like, Claire, it led to the success of the initiative. And from what you presented, it sounds like it's going so well. In relation to your own role, how do you feel you've developed in your role? I know you talked about developing technical skills, and I think we've all had to do that in the last few months. But in terms of your own role, how do you think things have changed due to this experience?
Absolutely, I think there's been enormous changes. I never really, pre-COVID, saw the use of technology as much in my own role, and how I could engage with women in the service using that technology, as a nurse and as a midwife, especially. So that's massive changes, you know. And I can see now the women who are under our care are very used to technology. They're women mainly in their 20s, in their 30s. They're used to using their smartphone. They're used to having information easily at hand. So we really can use that to our advantage now in giving women information and empowering them in meeting their needs in other ways. So it's been a really, really positive experience with that regard. But I feel a lot more confident now to try new things like that to meet their needs. It's been a very positive experience overall, and I feel that this is a service that we won't change, going into the future. We will combine it, hopefully post-COVID, or a time where we can maintain the safety of the women coming back into the hospital for their antenatal education. But I think we will offer a combined approach to that, because women have really enjoyed the accessibility of the online education sessions, as well as, before coming into the hospital. So I do feel that it has absolutely empowered me as a midwife. I've had colleagues who have, come to me to look for support for setting up their own WebEx sessions as well online, or using the technologies available to us at the minute for their department. So that's given me confidence as well in this area to develop, and it's exciting. I guess the future is exciting of where we go from here.
Claire, thank you very much. There's huge learning in what you've presented, and that is really key for this webinar series, and this webinar in particular. So thank you very much for presenting on the actual experience of your initiative and implementing it. We're going to move on to our third panelist now, who is Yvonne Moloney, as I said, and Yvonne is a registered AMP in diabetes in University Maternity Hospital, Limerick. Yvonne, lovely to see you again, and thank you for taking the time to join our panel today. Yvonne, it's from reading your submission and from talking about it, it's really been a fantastic initiative. Could you tell us about the initiative that you implemented in response to COVID-19?
Thank you, Marie. I deliver and lead the Diabetes and Pregnancy Service here in the University Maternity Hospital in Limerick, which is part of the UL Hospitals group. So hence, prior to COVID, we had streamlined a lot of our services, particularly around group gestational diabetes mellitus education. So about once a week, we were putting at least approximately about 20 women into a room and educating them on gestational diabetes. Also, once a week, we had gestational diabetes insulin initiation group sessions. So these women, about 30% of them require insulin treatment. So hence, these women were booked into the session and they were group educated, and there may be anything up to 10 women in that session. We also had, I led on follow-up diabetes and pregnancy clinics, which were face-to-face clinics, and those clinics had approximately 20 to 30 women booked into them weekly. So we had a lot of group sessions and a lot of face-to-face contact. So to provide safety for us and provide safety for the women, I had to look at some kind of remote access. So initially what I did was I took, I looked at all the available virtual platforms that were available to us and the supports I had. The urgency was because diabetes and pregnancy is they're a high risk group of patients. Plus the other factor that you're looking at is it's a progressive condition. These women need to be seen approximately once a week or even more in some cases. So I looked at all the virtual platforms and I looked and see what was most available and easy to use. So the Attend Anywhere appeared to be the one that was most suitable for our situation. I started small. We started with the group gestational diabetes sessions. We moved on then to the group insulin initiation sessions, and then I implemented it for the follow-up clinics for my RAMP clinics. So that's where we're at the moment. Hopefully we'll move on to more clinics and get it implemented there. As your previous speakers had said, there was a lot of support for us around. There was everything was coming at us in 3s and 4s, and you were looking at it thinking, what am I going to be able to implement here with the resources that you had? So that's where, as I said, we're at the moment. I suppose I had the privilege of having very recently done an organisation development project, which the outcome was the implementation of an app. So that did give me a lot of insight and help in developing the remote sessions.
It was such a change, Yvonne. I've no doubt that the previous experience was a great foundation for you as you tried to implement this change in a very responsive way very quickly. Can I ask you, did you use any tools? Because it was a change process. There's so many tools out there in terms of to support any change. Did you use any tools during this time?
I suppose what was in my favour is I was very familiar with the HSE change management guide that was actually updated about 2 years ago. It's a very big document and it has a lot of tools in it. So I was able to pick out the ones, and I had actually used some of those tools in our own service very recently, not realising that this is what I was going to be using them for, but I had a lot of the analysis done, especially using things like the SWOT analysis, the PESTEL analysis, and the cultural analysis in our area. So I had a fair idea where I was going. I had a basis, and that gave me a certain amount of knowledge that was invaluable when I was trying to implement the virtual sessions. Those tools too will give you an idea, where are your strengths, where are your weaknesses, what do I need to do here, where do I need to try and go to access more, even like equipment, where do I need to go and access staff, where do I need to get supports. I suppose some of the supports and so on that I used was I looked at, we'll say, telehealth and telemedicine is already fairly well established in the States. It's fairly well established in some areas in the UK. So there was some guides and so on available around there that I looked at. Now, some of them were way ahead of us and were far down the road from where we are at the moment, but there was parts that I was able to pick out and utilise. The other thing, there was a document, it was a guide developed by the Acute Care Division, which also gave a lot of guidance just locally, what you could do. It was originally developed in the early stages for the consultants and the doctors, but there was parts of that I could use as well. Simple things like, ensuring that there was a private space, ensuring that it was a well-lit space, if things like that, privacy for the women, that doors weren't open, people weren't walking in and out when you were on the virtual consultation. Simple things, but at the same time, these are things that people are not familiar with. You can't run a virtual clinic on a corridor. Little things like how to manage appointments, how to manage non-attenders, and backup systems if the Wi-Fi goes down.
Will be helpful for people listening, and the use of tools is really, really good in terms of guiding processes. In relation to the virtual consultations from a service provision perspective, what were the positives and negatives of your experience?
The main positive I saw was accessibility for the women. A lot of these women have young children at home. They couldn't bring them into the hospital. They may had a husband at home as well. He's not working, he's working from home, couldn't get in. We've a lot of frontline workers as well. I think Fiona mentioned our women from the other countries which would have a high rate of gestational diabetes, and they were actually our colleagues in some cases. They were frontline workers, and they were trying to get time off work. They couldn't be coming in and out to another hospital and maybe working somewhere else. Transport is an issue. We work, we have a remote, we'll say like West Clare, North Prairie. We have patients coming maybe from an hour and a half, 2 hour drive. So, a virtual consultation is much more valuable for them women. Waiting around, waiting times in clinics is a big issue. And, if you have a time for your virtual clinic, you log on at your time and you come off at your time. Now, there are other sides to that. from the point of view for us as staff members, you know, you have to have your clinic prepared. You have to have your results of recent blood tests available, your uploads from your meters, uploads from pumps, whatever is required. You need to have all that ready going into your virtual clinic. So that is, I suppose, you know, while it's an advantage for the woman, it creates a little bit more work for us. It's, you know, it's convenient as well. You know, it's very convenient to be able to log on at 3:30 on a Wednesday, and I know I'm going to be off at 3:45 for that woman. It's quick. It improves workflows as well, because, you know, it keeps the clinic moving. There aren't 30 people waiting outside to get in. This, you know, things like that. It certainly makes it a lot easier for the women. I suppose one thing we saw here is we would have, as I said, a lot of women from the ethnic minorities, and they engaged much better with our services than they would in comparison to face-to-face clinics.
And it sounds like, Yvonne, there's been a huge amount of positives with it. Has there been anything you'd say that hasn't really worked well with it, or that, you know, on reflection you would do differently?
I suppose we're making a lot of what I would call rapid cycle changes. As we, you know, we're learning, the patients are learning, and you see little things that you can tweak as you go along. I suppose one of the things I find is you cannot do a physical examination. So very often you come across something on the virtual consultation and you have to bring the patient in. So that's the lack of physical examination can be an issue. Not very often we've ways around it, you know. Sometimes you can, the more you question the woman and you get the information, you know, it might be something as simple as oedema or whatever, that you need to see what is going on. But, you know, by questioning the woman, you can get a lot more information, and that comes with experience as well. The other thing is the lack of measurements being available to you during the clinic. So you need to think, it's really by nearly workarounds, you have to think about who might actually take this blood pressure for me, who will do the blood tests, who will do the urinalysis. So, you know, GPs are excellent, and also our antenatal clinics, we were able to work around that. So it's thinking outside the box a lot of the time.
And Yvonne, can I just ask you, if you were to, you know, talk to midwives now around implementing a change, from your experience, what do you think they most need to be aware of in any change process?
Well, I've had a lot of conversations with my colleagues around the maternity hospitals in recent weeks, and I would say keep it simple. Keep it small initially. Look for early wins. Look for the clinic that patients are really well engaged. Now, usually newly diagnosed women are really well engaged. They're anxious to get the information. Maybe start with them. Maybe start with the ones that have access to technology, that have Wi-Fi at home. Things like that. Start easy, start small, and keep it simple. One-to-one with your patient first of all. Move on to maybe a couple of more patients and build it up. I suppose the beauty of Attend Anywhere is the max in a group is 6, and you don't need their email addresses. So that was where I felt it was simple, it was easy, and it was easy for us as healthcare professionals, and also easy for the patient.
Yvonne, thank you so much. I think it's great, the work you've been doing, like the others, and I think you've given some really good tips in terms of supporting other colleagues who are listening today as to how to consider, you know, bringing in change. And I think your message around keeping things simple just seems to be a theme at the moment. If we just start small and go from there, things seem to work out very well, especially during a crisis situation like we're in at the moment. Yvonne, thank you so much. I'm going to move on to the fourth panelist, who is Carmel Connolly. As I said, Carmel is the Clinical Midwife Manager too in Patient Education Services from Salta University Healthcare Group. Carmel, very welcome.
Yeah, I'm delighted to be here.
Carmel, your initiative, like the others, you know, was obviously introduced in response to COVID-19. Can you talk us through the change that you introduced to your service due to COVID-19 back in March 2020?
Well, on the 11th of March, the WHO declared that we were now in a pandemic. So as a parent education department, we had to redesign all our services. Normally women came to the hospital for group classes, but now due to the restrictions, they weren't able to come, and they were extremely anxious. It was a very uncertain time, and there was a lot of change going on. So I had a discussion with my team here, and we have a fantastic multidisciplinary team in the antenatal education department. And we came together and we formed virtual classes. And we've had 1,000 people through between March and July, so they've been very, very successful. But with any change, it takes time and it takes good communication and working with people and building relationships. And you know, we were looking here, we had an online booking system on our website. So we added, and we had just finished our virtual tour, so we were able to add that to our portal as well. And we put up a hypnobirthing script, and we put up some roadmaps. But the virtual classes have gone very well, but we had to communicate out to our partners in the community. So we sent out a letter to the GPs to inform women how to access the classes. We sent out letters to all our clinical partners here in the unit, because communication was vital, because there was so much happening at such a pace. And the women have been very happy with them. Personally, I had to work with IT. They were very supportive as well, you know, to learn how to use Zoom, the chat bar, because when you're in a group setting, you're used to face-to-face and you can pick up things, whereas, you know, in a virtual setting, to learn how to read people differently and offer the chat bar if they want to ask a question rather than a group scenario. But I had a fantastic team and I had great support from my own management team as well to initiate the initiative.
Carmel, I know from speaking to you and from your submission that you really took a systems approach to leadership and innovation with this initiative. Can you tell us how you implemented it using that approach?
Well, when I hear the word systems, I always think of framework, and there's so many models of improvement out there. But I suppose I have a preference for Lean Six Sigma, because Lean is all about creating value in the eyes of the customer and getting rid of waste. And Sigma, you know, the Six Sigma part of it is about reducing variation. So with any system, you know, it's made up of 5 parts: define, measure, analyze, improve, and control. So I got the group together, the whole team, and we looked at the process as it was, as is, and we were veering towards the process to be. And we were making decisions based on data, because data-based decision making is very important. So looking at the process, we needed to get the women in, or they couldn't come in, we needed to get out to our women. And then we were doing, in the improved part of it, we were doing PDSAs, which is in a lot of improvement models. So you plan, do, study, act, and you're testing the idea, you're continuously redesigning what you're doing. So at the start, you know, we started the classes, there were just midwives involved. Then we increased the multidisciplinary team, and we kept asking the women at every session, what matters to you? Because it's very important, you know, in any system, that the mother is at the centre, or your service user, and you build around that. And that's really what creates value. With any model of improvement, then you're testing ideas with the PDSAs, and it's like the cycle of change. If it works, great. If it doesn't, you redesign. And as Dr. Michael Ryan said at the time, you know, speed trumps perfection. We were in the middle of a pandemic. We were all in it together. We were all working together. We were all helping each other. And we were trying to be kind to each other as well, because we were nervous ourselves. But the women really was our central focus. But I think when you're looking at any change, there's a lot of learning with it. And, you know, you have to use a scientific approach. And with Lean Six Sigma, it's the science of continuous improvement. So you have, you know, your define stage where you look at the problem, you define it, then you measure, you know, with your data, you're improving, and then you have your standard operating procedure. But for us, we had to change our visual aids, you know, for example, for all our classes, because they're now very visual. So we had to change how we did things. But, you know, if the why is right, the how will come. If it's about the mother, you will change to meet her needs. So even though you might be nervous, be brave, try it, work with your team, because it's all about teamwork and the mother in the middle.
Carmel, thank you for that. I think your messages are so fitting and important, and you're absolutely right. And it's wonderful to hear the mother in the centre, and that's only right. But also to use the evidence base behind what you were actually doing, and the Lean Six Sigma process as well certainly adds that credibility to your initiative. Carmel, as previous speakers have said, and we've heard it actually in other webinars as well, communication is absolutely key for the success of any initiative. And it's certainly an essential ingredient during the pandemic for anything that we're doing in any aspect of our lives, be it healthcare or outside of that. How did you achieve this in redesigning your new process for antenatal online classes?
Well, I think, you have to think of your values, and in terms of communication, respect is the most important value of all. Respect for yourself, respect for the mother or your service user, and respect for the team that you're working with, because everyone has a role in that cog of change. And, having empathy for people, like it was a very difficult time during that crisis at the start, the speed of information coming through. So be empathetic for whatever group of people you're working with, be it the midwife, be it the doctor, be it the dietitian, be it the physiotherapist, be it the social worker. Because for the woman, it's the bigger the team, the more value for the woman. But when you are in that role, respecting people and being kind to each other, reminding each other, and valuing what people have to say, and giving meaning to their work, and giving them the space to brainstorm. And we used to have meetings here, and I used to use our visual board, because I find it's great for meetings. It's shorter, and we'd all look at it and say, right, we have 200 women here looking for classes. How can we run them to be, most effective? And you're improving patient safety as well with this, and cost saving, because, you're being more efficient with your time, and everyone has a say, everyone has a role to play in the classes. So it's far more effective for the mother and far more beneficial, and creating more value for her. But of all the ingredients, and there's many ingredients when you're looking at, we'll say, leadership values, there's wisdom, there's empathy. I think respect is central to all. Respect for your team, it's central.
And Carmel, we've spoken about leadership over the last few days, and certainly, in terms of what you've just described there, you've really highlighted the key aspects of leadership in terms of competencies, empowerment, respect, and values as well. So that's key to this presentation as well. And it's so important in any initiative that we really demonstrate our leadership skills. Carmel, just on to the last question. There was, I'm sure, and you've mentioned a lot of positives to the initiative. Was there any negatives, and how did you overcome them?
Well, I suppose the big negative for me is when you're in a group and you're facilitating a class, you pick up the woman that might need that extra 15 minutes at the end, that might be worried about her husband losing his job, or she might have just lost her mum, or a bereavement, something like that. And you'll pick it up, looking at the woman, and, you'll be able to give her that 15 minutes at the end that she needs. So I was looking at this myself, and I was saying, how can I do this better in a virtual world? So I get the mums to, use the chat bar. So if they have any concerns, they can use it privately to me, just to me, not to everyone. Or I give them my phone number so they can ring me afterwards. And that has worked very, very well. I suppose that's the one thing I found with it, really. You can't replace face-to-face. But having said that, I will never go back to the way I facilitate groups now, because we don't have any waiting lists. We have 100% capacity. We have the whole team involved. We now have the stores in Galway doing car seat safety from the store. They can link in. And from the mother's point of view, she doesn't have to worry about parking. Her partner can be with her all the time. And the new national standards came out in January for antenatal education. So they were a great framework as well, to be benchmarking against those standards. Because, to promote excellence, you have to strive to achieve the standard. And also there was another national forum set up as well to support antenatal educators. That was very supportive as well for me personally. If you could talk to the other people around the country, what are you doing? How can we do this better? How can we help each other? How can we share the information? Because when the only focus is the mother or the service user, you know, that is the most important agenda. There is no other agenda. And as health professionals, our role is, you know, to mind that mother, give her evidence-based practice, give her the best possible service that we can give her, in whether it's a pandemic or not. And that leads to patient safety. That leads to kind, wholehearted caring, leading from the heart, being empathetic, what matters to you. And I think that's very important for us as health professionals.
And Carmel, I think that's a wonderful end to this panel presentations. So thank you so much to you for taking the time to present. I'm now going to hand over to my colleague, Dr. Clare Lewis. And Clare has been taking notes throughout the panel discussion and has really been summarising the main points that have been presented by our expert panel. So Clare is going to present these now. Thank you very much, Clare.
Thank you, and I feel really privileged to have heard all of the speakers today. I'm completely enamoured by their leadership and, you know, how they've innovated in incredibly difficult circumstances. And what's really come through is how COVID has touched upon every service and every area of care, and how people have actually delivered new ways of working for the benefits of, in this instance, mothers and families. What I feel I'd really want to do is to go through each speaker, because I think that there's been so much that's been presented that our audience will learn, you know, there'll be valuable learning. So from Fiona's perspective, I think what came through is what she said was a mother's due date, it's not the same as elective care, and the services do have to continue. And what was very clear and what came through was how services were mobilised and looking for alternative care pathways, such as daycare, use of remote monitoring, and having that rapid access to diagnostics to determine level of need. And the importance of communication for staff, so having one central point of contact. And I thought it was fabulous to hear the use of social media platforms to make sure that staff were up to date and they were able to engage and felt supported. And what came through was the importance of supporting staff to become resilient in very complex environments and providing the necessary health and well-being. And, you know, I really to hear about the impact of overseas staff, that there is a lot of learning there and what we need to do to support our overseas colleagues working within our Irish healthcare system. So I thank Fiona for her presentation. It was excellent. I just wanted to move on to Clare, and you know, breastfeeding education, as she eloquently highlighted, will impact on their breastfeeding journey. And the new ways of working and what she did in delivering virtual breastfeeding workshops, having access to different platforms, virtual, you know, having a central point of contact, and developing that online program that didn't compromise on quality, efficiency, and effectiveness, and engaging the mothers and the staff engagement and what the information processes were, so the technology to engage, the staff support and the buy-in, and the challenges, so upskilling technology, because we take it for granted, but there is an upskilling piece, not just for staff, but also for those that are engaging, how to record information differently, so having even access to an email, and really how technology is enabling our roles in both nursing and midwifery. I'll just move on now to Yvonne and you know, what she actually delivered in terms of diabetes and the pregnancy service, being able to continue that specialist care, which is vital, and transitioning over to remote monitoring, remote platforms, and utilising the Attend Anywhere. But I think what she eloquently highlighted was the importance of starting small, test the process, test the design and the functionality, and then expand to other groups, and how you can utilise national strategy and policy, so that whole change management in HSC process piece, and applying a framework so you can look at what are your risks, how do you mitigate against these, and information mapping So how are you going to facilitate the virtual consults? But I think what came across very clearly was there improved accessibility for mothers. There was convenience. It enabled more efficient and effective delivery of care, and it improved workflow processes and improved mothers' engagement. And I think what's exciting is, you know, having that blended approach as we move forward, and hopefully as we move out of, you know, the COVID pandemic, that you can have that blend of direct and remote care, and you can offer choice and accessibility to access maternity services. And just finally, Carmel's piece, you know, it was wonderful to hear how the redesigning of antenatal education and the reach that was, you know, the amount of women that it's actually reached to deliver online classes and virtual sessions, and thinking very differently, and the processes that are required. And it was excellent to hear how that she actually looked at what the data was telling her, and how we needed to engage both the data and the evidence base to really deliver person-centred antenatal classes, and starting with sessions that what matters to me is so important, and how it flexes around the needs of women and the environment in which we find ourselves. And I think what was excellent to hear as well is that compassionate leadership, creating that value within the team and transferring that to the women that you care for, so creating that values and leading by your values. And so care, compassion and commitment. And I think, you know, what is clear is that virtual care and delivering care through remote platforms, it can be more challenging. How do we pick up on those cues that we would see when we see people directly? But I think what was clear is that it is about educating people differently, so that they can engage through the group chat online, and also about educating them that they need to reach out to you afterwards, after these sessions. But just to conclude is what's really evident with all of these initiatives is how they've actually embedded the vision outlined in the maternity strategy, and they've also reflected on the principles of sláinte care. So looking at the health and well-being to give babies, mothers and their families the best start, and so that they feel empowered and supported, bringing care closer to home, and for women to have access to safe, high quality care that is women-centred, and that maternity services are underpinned by strong and effective leadership and strong governance that's in partnership with women. So I'm continually inspired by the responses of nurses and midwives during this pandemic, and I'd just really like to thank all our speakers today for sharing your important work here. Thank you very much.
Claire, I think you've summarised the key points so well, and definitely even in listening to all of that, there's been such significant learning here today. So thank you. I'd also like to obviously thank the panel. You've spent a lot of time preparing for today, and it's been wonderful working with you. I really am very grateful, as are my colleagues, to you for coming today and for presenting on this important topic.